Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from OTSCA.
This program is presented by Medscape Education Global.
Hello, I'm Jonathan Barrett. I'm a nephrologist from Leicester in the UK, and welcome to today's program entitled Immunopathogenesis of IgA nephropathy and the Evolving Treatment Landscape, a focus on the B-cell pathway. I have the privilege of being joined today by Vlado Perkovic and Hidu Heerspink.
Thanks, John. Hi, everyone. It's Vlado Perkovic here. I'm a nephrologist and clinical trialist from Sydney in Australia. I've been working in IgA nephropathy for many years and looking forward to the discussion today.
Hi everyone, my name is Hido Heerspink. I'm a clinical trialist and clinical scientist at the University of Groningen in the Netherlands, and I have been involved in clinical trials in patients with IgA nephropathy, and I also look forward to the presentations and discussion today.
In today's program, we will discuss the role of B cells in the immunopathogenesis of IgA nephropathy and the rationale for emerging therapies. But before we do so, how common is IgA nephropathy? Well, if you look here, you can see the estimated prevalence of IgA nephropathy in different parts of the world. And in my view, this is a massive underestimate because, of course, the only way we can diagnose IgA nephropathy is with a kidney biopsy. And the accessibility and affordability of kidney biopsy varies across the globe, as does an individual's nephrologist's threshold to actually perform a kidney biopsy. But these are the data we have at the moment. I imagine that these prevalence figures will increase now that we have very exciting, safe, and effective treatments for this disease. We know there is a significant lifetime risk of developing kidney failure for those people with IgA nephropathy, and it's estimated globally that 1 in 10 people on dialysis is on dialysis because of IgA nephropathy. That's not generally what I see in my practice in the UK or we see in Western countries. It's predominantly driven by the incidence and severity of the disease in East and Southeast Asia, where the disease is more common and more likely to result in kidney failure. And of course, those people who develop kidney failure and have a kidney transplant, there is a significant risk of the disease recurring. And in some of those people, there is a risk of loss of the graft and having a return to dialysis because of recurrent IgA nephropathy. As I've already mentioned, the disease is more common as you move from the west to the east. It's relatively rare in Black people. And in the West, there's a 2-to-1 male to female ratio, which is lost as you move to East and Southeast Asia. And as you can see on the map, data from genetic studies have shown that the frequency of the genetic risk alleles that we've identified in genome-wide association studies similarly increases in prevalence as you move from the West to the East. Now, we've done a lot of work on the prevalence and risk of kidney failure in patients with IgA nephropathy in the UK using the Rare Disease Registry RaDaR. And to be eligible to get into RaDaR, a patient needed at any time to have had more than half a gram of proteinuria or a GFR less than 60 mils per minute. So in my practice, this is anyone I diagnose with IgA nephropathy in current practice. But importantly, it doesn't include those patients we know have a very good prognosis who just have isolated non-visible hematuria. And what we found in this study was a significant lifetime risk of kidney failure. We saw the median age at diagnosis was 45.3 years. Median age at kidney failure or death was only 48 years, and 50% of the patients reached kidney failure or died during follow-up. You can see here that data mapped out. The most striking feature here is if you're a child diagnosed with IgA nephropathy in the UK at 20 years from diagnosis, half those children have developed kidney failure, and 75% of adults have developed kidney failure 20 years after their kidney biopsy. And this is during an era where priority of treatment was optimized supportive care with good blood pressure control and RAS inhibition. So clearly not enough to slow the rate of loss of kidney function significantly and prevent kidney failure. Here again, we look at outcomes, but this time by age at diagnosis or age at kidney biopsy. And if you look at here at someone in their mid 50s, you can see by the time children get to someone my age, three-quarters of those children have developed kidney failure. And if people were diagnosed between the ages of 18 and 40 years, by the time people reach my age, two-thirds of those adults have developed kidney failure. Quite a striking outcome in a disease that we traditionally thought of was benign and didn't really lead to kidney failure in a significant number of patients. We've always known that the high level of proteinuria predicts how rapidly someone is likely to develop kidney failure. And one of the striking things from the radar analysis, which has now been replicated in a number of other studies, is that the risk of kidney failure is significant, even at levels of proteinuria we previously thought was safe. And here you can see proteinuria lower than 0.5 grams or 0.5 grams to 1 gram. At 10 years follow-up, 1 in 4 of those people have developed kidney failure. So we really need to take a renewed look at what our proteinuria threshold should be for a kidney biopsy, our proteinuria threshold should be for treatment, and what our target proteinuria threshold should be to say a treatment has been effective in treating the disease and slowing the loss of kidney function. And so when we think about how we treat IgA nephropathy, we need to remember we're trying to target two very different pathophysiological processes. The first is the IgA nephropathy itself, the immune complex mediated glomerular disease. But as we know, this disease presents late, and therefore by the time we as nephrologists get our hands on these patients, they will have developed established nephron loss. And therefore all of those initially adaptive and then maladaptive responses within those remaining nephrons are in full swing. The impact of glomerular hypertension and hyperfiltration, the impact of proteinuria on the tubular interstitium, the impact of systemic hypertension. Very distinct but different pathophysiological processes to those that drive the formation of circulating immune complexes and the immune complex mediated kidney damage that is characteristic of IgA nephropathy. And if we accept that these two processes are ongoing and ongoing simultaneously, we need to accept also that we need two very different therapeutic strategies to try and prevent or slow as much as possible ongoing nephron loss in our patients. These data, again from radar, really tell us the challenge we face. And what we did here was we simply took the GFR on the day of kidney biopsy, the age of the patient, and we predicted, based on different rates of loss of kidney function, what was the likelihood of that patient developing kidney failure in their lifetime. And you can see here, based on the GFR of real patients in the UK, that 100% of patients diagnosed before the age of 40 will reach kidney failure if they lose 3 mils per minute per year of kidney function for the rest of their life. And even when we get down to 1 mil per minute per year, 40% of patients diagnosed before the age of 50 will reach kidney failure. And this is because our patients present young, and when they present, they have already developed established kidney failure. The typical eGFR, as you saw in radar and in my practice, is a GFR between 50 and 60 mils per minute. And what that tells me is my patients, before I even get an opportunity to intervene and treat them, have lost over half their nephrons. So I don't have time to wait to decide how I'm going to treat them or monitor them. I need to get on, make a diagnosis, and treat these patients as quickly as possible if I've got any hope of reducing the risk of lifetime risk of kidney failure. And so here we can see the new approach to thinking about IgA nephropathy that we've encapsulated in the recent update to the KDIGO guideline. We need to think about preventing kidney failure in the lifetime of our patients. To do that, we need to address the immunological aspects of the disease, which is what we're going to talk about in the remainder of this podcast. And we need to also think simultaneously about targeting those generic CKD changes that we treat for all forms of kidney disease. And our goal must be to try and get that future loss of kidney function back down to the physiological state, which we think is on average, patients lose 1 mil per minute per year of kidney function after the age of 40. So let's dive deeper into the pathogenesis of IgA nephropathy. So what we can see here are the fundamental steps that we think go to formation of those immune complexes that deposit within the glomeruli and trigger inflammation and scarring. And Hido's going to talk through these in great detail. But what I just want to show in this slide is we now have a variety of drugs that target different aspects of this pathogenic cascade. And what we're going to focus on in this particular session are therapies designed to target the B cell, IgA class switch recombination, and generation of the IgA that fundamentally drives the formation of immune complexes. And we have made quite a successful progress in generating new therapies. And you can see here in this timeline to the far right the number of different therapies currently being evaluated to treat IgA nephropathy. It is mind-blowing how far we have come over the last 5 to 10 years. But as I say, in this podcast, we're going to think about B-cell directed therapies. So, Hiddo, why is it important to target the B-cell pathway in IgA nephropathy?
Thank you, John. I believe that targeting the B cell activated pathway is very important because we target a key aspect of the pathophysiology of IgA nephropathy. So now let's take a closer look at the pathophysiology of IgA nephropathy. As you know, IgA is primarily found in mucosal secretions in the respiratory and digestive tract, and it plays a vital role in preventing pathogens entering the body. IgA is produced by mature B cells, and its production requires activation and differentiation of naive B cells that produce IgM or IgD into IgA expressing B cells within the mucosal environment. More specifically, the production of IgA by mucosal B cells is driven by T cell dependent and T cell independent pathways. After antigens are taken up in the gut by specialized cells, and these are M cells and dendritic cells, naive T cells are activated and interact with naive B cells, driving the switch from production of IgM or IgD into the production of IgA, which is the main antibody type involved in mucosal immunity. Dendritic cells may also produce the cytokine's B-cell activating factor, or BAF, and a proliferating inducing ligand, or APRIL, two critical cytokines that play a significant role in B-cell development, survival, and immune responses. Both BAF and APRIL promote T-cell independent differentiation of naive B cells to IgA expressing cells. We don't know precisely why activated B cells produce galactose-deficient IgA, which is the key factor involved in IgA nephropathy. But it appears that dysregulation of glycosylation pathways, that is, adding sugars to IgA, is involved. Other inflammatory factors may also be involved, such as the cytokine interleukin 6. And finally, BAF and APRIL can also produce galactose-deficient IgA directly. Galactose-deficient IgA-producing B cells then traffic towards the effector sites via the lymphatic system. And galactose-deficient IgA, abbreviated as Gd-IgA, appears in the circulation either because of an overspill of Gd-IgA from mucosal sites or because of mistrafficking of B cells to, for example, the bone marrow. The increased Gd-IgA circulating in the body plays a key role in the pathophysiology of IgA nephropathy, explained by what's now known as the 4-hit hypothesis. The first hit involves the overproduction and release of Gd-IgA into the circulation. In the second hit, this abnormal IgA triggers the formation of autoantibodies that bind to Gd-IgA to form immune complexes. This is the third hit. And finally, in the fourth hit, these immune complexes deposit in the kidney's mesangium, leading to glomerular injury, inflammation, and ultimately fibrosis. The B cell pathway thus plays a central role in initiating the 4-hit process, which is why it's a key target in efforts to prevent or slow the progression of IgA nephropathy. With that in mind, let's now take a look at some of the emerging therapies focused on targeting B cells in this disease. And I'll hand it over now to Vlado, who will start with the first treatment.
Thank you, Hiddo, and thanks, John. I'm going to now take us through some of the data. It was fantastic to see such a detailed overview of the importance and the central role that the B cell has in the development and progression of IgA nephropathy. So the first agent we're going to look at today is sibeprenlimab, a selective IgG2 antibody that binds to and inhibits the biological activity of APRIL. And APRIL is a key factor that drives plasma cell proliferation and antibody class switching, as Hido's already told us. So by inhibiting APRIL, we have an impact on a number of the hits in the pathway that Hido's just described that drive IgA nephropathy. We potentially reduce the pathogenic production of galactose-deficient IgA1, and we may also inhibit autoantibody production, as well as perhaps having an impact on the inflammatory process within the kidney itself. And collectively, these effects have been hypothesized to lead to reduced proteinuria and stabilized eGFR, and ultimately kidney protection. The phase 2 ENVISION trial was reported a year or two ago, and this looked at 3 different doses of sibeprenlimab in people with high-risk IgA nephropathy, and showed that with the 2 higher doses, 4 and 8 milligram per kilogram intravenously, there was an almost 50% reduction in proteinuria and an apparent stabilization of eGFR that looked very promising compared to the loss of 7.4 mils per minute seen in the placebo arm. So this was very promising data and led to the development of a 400 milligram subcutaneous dose, which has roughly the same sort of exposure as the 4 milligram per kilogram IV dose, the middle dose, had in the ENVISION trial. So that phase 3 trial is the visionary trial. 530 participants were randomized after being screened for up to 60 days, 1-to-1 to either 400 milligrams of sibeprenlimab subcutaneously every 4 weeks or a matching placebo, and followed for over 100 weeks. The primary analysis will be undertaken at week 40 and will compare the urinary protein creatinine ratio at 9 months compared to baseline. And subsequently, the trial is ongoing and participants will continue to be followed until the last participants reaches 24 months, at which point eGFR slope data will be analyzed, but that analysis has not yet been done. This is the flow of the study participants after screening 901 participants. 371 were screen failures. 20 were randomized into an exploratory cohort because they had an eGFR of between 20 and 30, but otherwise met the inclusion criteria, and they'll be analyzed separately. But the main cohort consists of 510 participants, and there was a pre-specified plan to conduct an interim analysis looking at the proteinuria effect once 320 participants had reached 40 weeks. And that's the data I'm going to show you today. You can see that 7 and 8 participants respectively discontinued the trial by week 40 in the sibeprenlimab and placebo, so over 95% of participants stayed on randomized therapy out to week 40. These are the baseline characteristics in the visionary trial. The average age was a little over 40. About 2/3 of the participants were male, and a little over half were of Asian background. The median UPCR on a 24-hour urine was about 1.3 grams per gram, and the mean eGFR was 63 mils per minute. Most participants had had a biopsy within the 2 years prior to randomization. Almost all were on an ACE inhibitor or an angiotensin receptor blocker, and about 40% of this cohort were on an SGLT2 inhibitor. These are the main results of the visionary trial interim efficacy analysis. On the left-hand side, we see the effects on SPOT, urine protein creatinine ratio, which was a secondary endpoint, and we can see early separation between the placebo and the sibeprenlimab arms, clearly separated by 8 weeks, and that separation continues to grow over the 52 weeks shown here, so that at the 40-week point where the primary analysis was undertaken, shown on the right-hand side, placebo-treated participants had a protein creatinine ratio that had increased by 2.1% on average, whereas in the sibeprenlimab 400 milligram group, proteinuria was reduced by over 50%, giving us a placebo-subtracted adjusted treatment difference of 51.2% and a highly statistically significant p-value, so a very substantial treatment effect. Here are the data on safety, looking at treatment emergent adverse events overall and the numerically lower number in the sibeprenlimab treated participants compared to placebo. Treatment-related adverse events were similar. Fewer adverse events leading to discontinuation numerically in the sibeprenlimab arm, as well as severe or serious adverse events. And there was certainly no evidence of an increased risk of serious infections or of opportunistic infections, and there were no deaths in either arm of this trial. If we look in more detail at the safety data, and perhaps if we first off focus on the infection-related adverse events, which are highlighted here, we can see overall there's similar, a slightly greater number of COVID-19 cases in the sibeprenlimab arm compared to placebo, which is the reverse of what was seen in the phase 2 trial, suggesting it may be chance, but otherwise no clear differences. And I've also highlighted here injection site-related adverse events, and once again, really no clear differences between the sibeprenlimab and the placebo-treated participants. So overall, Visionary showed a significant 51.2% reduction in 9-month urine protein creatinine ratio on 24-hour urine sample, which was the primary endpoint, compared to placebo. The safety profile looks very promising, and the trial's ongoing to assess the effects of sibeprenlimab on eGFR at 24 months. And this is the largest IgA nephropathy trial conducted to date, with 530 participants in total. I'll now hand over to Hito, who's going to tell us a little bit about zigakibart.
Thank you, Vlado. The next APRIL inhibitor we're going to look at is zigakibart. So just like sibeprenlimab, zigakibart is an APRIL inhibitor. It targets directly the TACI-BCMA receptor, and in doing so, it targets the pathophysiology of IgA nephropathy. Zigakibart is currently being studied in a phase 3 trial, and at the European Renal Association meeting in Vienna, new data from zigakibart were presented and published simultaneously in the journal Kidney International. And that study was a study on the effects of zigakibart in healthy volunteers as well as in patients with IgA nephropathy. And the study showed that zigakibart in these patients with IgA nephropathy significantly reduced IgA, IgM, and the Gd-IgA by about 70 to 80% after 100 weeks of treatment. And as you can see, here IgG was only reduced by about 40%. But does this have clinical consequences? We can see the effects on proteinuria and eGFR. So in these patients treated for 100 weeks, zigakibart significantly reduces the protein creatinine ratio over time, with maximum effects seen after 100 weeks of about 60%. So although the study didn't have a placebo group, we would assume that the placebo group would have a stable protein creatinine ratio. So the effects are probably similar as we have just seen with sibeprenlimab in a placebo-controlled fashion. But most importantly, if we look at the GFR decline in these patients followed for 100 weeks, we see no changes in eGFR over time, suggesting that GFR in these high-risk patients with IgA nephropathy is stabilized with treatment with zigakibart. So a very promising drug, and that's why a phase 3 trial is currently ongoing, and the design of the phase 3 trial shown, it's a typical IgA nephropathy design. So patients are treated for 2 years with an interim analysis after 9 months to look at the effects of zigakibart given at a dose of 600 milligram one time every 2 weeks subcutaneous to assess the effects of zigakibart on proteinuria. And just like the other trials, adults with IgA nephropathy or biopsy-proven IgA nephropathy are enrolled who have a GFR more than 30 mL per minute and a urinary protein excretion rate of more than 1 gram per day and are already receiving ACE and ARB treatment, and in this trial, SGLT2 inhibitors, MRAs, as well as endothelin receptor antagonists are permitted. We have to wait until the results of this study are presented because the study is still enrolling participants. And if you participate, please help us to complete recruitment in this trial because it's a drug that will hopefully also add to the therapeutic armamentarium for IgA nephropathy. I'll hand it over to Vlado again, who will tell us about dual BAFF and APRIL inhibitors.
Thanks so much, Hito. Here I'm going to talk about 3 drugs that have similar effects on APRIL, but also block an additional receptor, the BAFF receptor, and therefore may have somewhat different effects, but obviously that will remain to be demonstrated with the data. So the first dual BAFF-APRIL inhibitor we're going to look at is atacicept, which has been studied in the Origin 2B study, a phase 2 trial enrolling 116 people with biopsy-proven high-risk IgA nephropathy who were randomized to 3 different doses of atacicept or placebo for 36 weeks. And in that study, at 36 weeks, the combined atacicept group, compared to placebo, lowered the mean urine protein creatinine ratio by 35% compared to placebo. It's a very promising data. And also demonstrated a stabilization in eGFR with atacicept compared to a progressive loss with placebo at week 36. In that trial, there was also a 60% reduction in galactose-deficient IgA1 levels compared to placebo, and a safety profile without any significant concerns. So again, promising data for atacicept, which have now led to the Origin phase 3 trial of this agent that will shortly report its data on these outcomes in a larger cohort. The second agent we're going to talk about is povetacicept, another dual BAFF/APRIL inhibitor, which is being studied in the Ruby-3 trial. The design is summarized here. Again, a similar population with slightly lower proteinuria threshold and 2 different doses of povetacicept, 80 milligrams every 4 weeks and 240 milligrams every 4 weeks. Here are the data that are available to date, and this trial is ongoing, I believe, showing, again, significant reductions in proteinuria out to 48 weeks, and in this study, very high rates of remission of proteinuria with stable renal function, as shown. Again, we see stabilization of kidney function in this study, no control arm, but in these patients, there was no real loss of kidney function out to 48 weeks, which is very promising, and very substantial reductions, again, in galactose-deficient IgA1. So promising data, but we await the phase 3 trial. The last drug I'm going to talk about is telitacicept, again, where a phase 2 trial is being conducted, relatively small, 44 participants, similar population to those recruited previously, and randomized to either placebo or 2 different doses of telitacicept. In this study, it was a 24-week primary endpoint of change in proteinuria. And these are the results showing a 25% and 49% reduction in proteinuria in the 2 different doses from baseline. And once again, we see stabilization of kidney function in the telitacicept treated arm with progressive loss of kidney function in the placebo arm, consistent with the results of the other agents that we've talked about so far today. And similarly, with safety data, no real signal of any concern there. The only issue with this drug seems to be a slightly higher rate of injection site reactions and perhaps slightly higher rates of low immunoglobulins, IgG or IgM. But promising data again, and we look forward to seeing the phase 3 trial data when they're reported, hopefully in the near future. So that's all from me on dual BAFF/APRIL inhibition. So John, over to you to tell us about bortezomib.
Thanks, Vlado. Yeah, so we've a lot of activity in the BAFF/APRIL space, but there are other ways of targeting antibody-secreting plasma cells, and one of those is the proteasome inhibitor bortezomib. This is a drug that I'm sure you've come across when you work with your hemato-oncologists who treat multiple myeloma patients. Highly effective treating myeloma, and we've had a little bit of data in IgA nephropathy in this small open-label study from the United States. And here we saw that treatment with bortezomib did result in a reduction in proteinuria in a significant number of those patients treated. But at the moment, this approach isn't being taken forward. But what we are seeing are other therapies transitioning from the treatment of myeloma through to the treatment of antibody-mediated kidney disease, and in particular IgA nephropathy. And one of these are CD38 depleting antibodies. I'm sure all recognize daratumumab, a drug that multiple myeloma hematologists use regularly to treat myeloma. And now we have 2 CD38 monoclonal antibodies, felzartamab and mezagitamab, that have been trialed in early phase studies in IgA nephropathy. So we can see here a lot of different ways of treating myeloma. Some of these we're seeing transitioning to other immune-mediated kidney diseases like CAR T therapy and lupus nephritis. But at the moment, it's the CD38 monoclonals that I want to talk about. So the first of these is felzartamab. It was evaluated in the IGNAS study. These data were presented at the ASN last year, and a manuscript is shortly to come out in Kidney International. This looked at, as you can see, a highly typical IgA nephropathy population that you've seen Vlado and Hido talk about in the BAF and April studies. What's interesting here, though, is you can see the loading of the treatment and then the observational period thereafter. And so the same dose of elsartamab was chosen, but different dosing frequencies in the three M1, M2, M3 arms. And then the part 2 of the study was conducted in a Japanese population. And you can see dosing occurring over a different frequency over the first 24 weeks of the study. And then there was an 18-month follow-up phase. Here are the baseline characteristics. And again, very typical of what you've seen already, significant proteinuria despite optimized supportive care, and reasonably well-preserved GFR. And what did we find in terms of proteinuria? Well, you can see here a nice reduction in proteinuria with felzartamab treatment. And you can see on the left-hand side of the graph in the white area when the doses were given, and then that gray box covers the off-treatment follow-up period for 18 months. And you can see there was suppression of proteinuria, particularly in the 9-dose arm, that was maintained throughout an 18-month off-treatment period. So reduction in proteinuria that could be sustained without continued dosing. And here you can see GFR, and you can see again in the placebo arm a significant loss of GFR over the 2 years, which was reduced substantially with treatment with felzartamab. In terms of immunoglobulins, as you might expect, this treatment reduced immunoglobulins during the treatment period, far less effect on IgG, in fact, than on IgA and IgM. And you can see IgG and IgM recovered far more quickly than IgA over that 24-month follow-up period. So in summary, what we see here with felzartamab is it is effective at reducing proteinuria in patients with high-risk IgA nephropathy. And actually you get a sustained reduction in proteinuria for 18 months off treatment. So this really does signal that targeting CD38 positive plasma cells is a potential viable option for our patients with IgA nephropathy. The treatment was generally well tolerated, and this drug is likely to go into phase 3 clinical trials later this year. We also have another monoclonal antibody, mezagitamab. You can see a dosing schedule over the first 24 weeks, and then the data in this presentation follows the patients for a further 24 weeks out to 48 weeks in total. And the treatment was given subcutaneously with this drug rather than intravenous with felzartamab. And you can see here upfront dosing schedule, weekly for the first 8 weeks and then bi-weekly out to week 24. Again, a high-risk IgA nephropathy population, almost identical to the other populations that you've seen studied. And you can see a reduction in proteinuria. This was not a placebo-controlled study, but you can see here sustained reductions out to week 48. So remember, a 24-week off-treatment period where we didn't seem to lose that proteinuria response. And on the right-hand side, stability of GFR over that 48-week period. In this small study, again, it wasn't controlled with a placebo arm, but very interesting data, again supporting the data from felzartamab that targeting CD38 positive cells, particularly plasma cells, has a potential future role for the treatment of IgA nephropathy. The drug was well tolerated, as you can see here, with no serious adverse events and no study discontinuations due to adverse events. But what we did start to see out at week 48 was the serum IgA and IgG increasing back to baseline, although the Gd-IgA1 did appear to still be suppressed, and that data will be presented at a later time point. And so really we have a lot of drugs coming, and it's a really exciting but also confusing time for nephrologists, because we now need to think, how on earth are we going to think about using these drugs in clinical practice? So Vlado and Hidu, I'll come to you first, Vlado. We've just gone through a lot of data. How do you think this is going to impact on the management of IgA nephropathy patients you see in your practice?
Yeah, thanks, John. It's very promising data and such an exciting time. It's remarkable how effective treatments targeting the B cell seem to be at reducing proteinuria, and in some of the early phase data, promising in terms of stabilizing GFR at least out to 12 months. Obviously, we need to see whether that effect is maintained out beyond 12 months, and we'll get that data over the next year or two. But incredibly promising data that we might be able to not just reduce the progression of IgA, but almost stop it in its tracks. And that, I think, could be a game changer for people with IgA nephropathy, but it really does depend on the efficacy and the safety data being as effective as the currently promising but relatively limited data suggests.
Thanks, Vlado. And Hiddu, it's wonderful to see drugs actually targeting the basic pathophysiology of the disease. We're now starting to move, I think, into the next era of treatment where we have precision medicines targeting processes we know are driving pathogenesis. What are you as excited as I am about this?
Oh, definitely. And these trials and these agents give us many more tools to improve the treatment of IgA nephropathy. And we have to rethink our approach, how we're going to sequence these drugs. Maybe we should start with all APRIL-BAFF inhibitors before we even start with ACE inhibitors and angiotensin receptor blockers, because we target the root cause of the disease instead of a pathway RAS inhibition that is not directly related to the disease. So there are a lot of remaining questions that we can now answer in the future. Do all patients need these drugs? Which drugs do patients need? And when do we initiate them? Early on or later on? And this requires studies. We are now doing the registration studies, but we need to do actually the implementation studies and the scientific answer, the important scientific questions that are now arising. So I'm super enthusiastic and I look forward to executing these studies in the future.
Thanks very much, Hiddu. Yeah, very exciting times. And I think we're only at the beginning of a journey in terms of how we plan treatment strategies for our patients going forwards. But at long last, we finally have the tools to be able to do that. So I'd like to thank both yourself, Hiddu, and Vlado for joining me today to talk through this exciting new emerging area within IgA nephropathy therapeutics. And I'd like to thank you for participating in this activity. Please continue to answer the questions that follow and complete the evaluation.
This program was presented by Medscape Education Global.